are live now, ma'am.
Yeah.
Good evening, esteemed faculty members and all the delegates. Thank you for joining. This is Sahiti on behalf of Shield Connect. Welcome you all for today's webinar, Pinnacle News Series, Episode 18, in association with Ambala, Dibrugarh, Akluj, and Salem OBGYN Societies. And today's topic is anemia in pregnancy. So let us start the webinar with Saraswati Vandana. It's my privilege to introduce the MOC of today's webinar, Dr. Madhumita Arun Karthik ma'am. Ma'am is the consultant obstetrician and gynecologist from Salem and treasurer of Salem chapter of Tapisa. I welcome you, ma'am, and I hand over the session to you.
Yeah. Thank you so much, Sahiti. So it is my pleasure and privilege to introduce to welcome you all, faculty and delegates, to this webinar series brought together by Professor Dr. Sampath Kumari ma'am. It's my bringing together all corners, all four societies, one from north, one from east, one from south, and one from west, every 2 weeks in this Pinnacle News webinar series. Ma'am, slide please. So it's my pleasure to introduce Sampath Kumari ma'am, who is a professor and HOD at Sri Muthukumar Medical College and Hospital. And she is the past Vice President of FOXY, Senate Member of Tamil Nadu Dr. MGR Medical University, National Corresponding Editor of JOGI, Founder Secretary of Tamil Nadu Federation of Obstetric and Gynecology, and she's the present President of OXY, and also the retired Deputy Director of Institute of Obstetrics and Gynecology at Chennai, present Board of Studies at TN MGR Medical University, and she was a past chairperson of FOXY Adolescent Health Committee, and she received the first ICOG Distinguished General Council Member Award, and she is the chairperson of Women's Wing of IMA Chennai South, and she's also received the award in IMA National President's Award and IMA Tamil Nadu State Branch Award. Over to you for the welcome address, ma'am.
Thank you, Dr. Madhumita. I welcome you all for this Pinnacle News series. This is episode 18. We conduct one obstetric series and one gynae series. As Madhumita told, we have societies from north, east, west, and south. Today we have Ambala, Dibrugarh, Akluj, and Salem Society. I welcome Dr. Poonam Lamba, the president of Ambala, and Dr. Aditya Garg, the secretary, and the Dibrugarh president, Dr. Pranay, and the secretary, Jasmina, and Akluj, Dr. Revati, president, and Kavita Kamble, the secretary, and the Salem Society, Dr. Saravana Kumar, and secretary, Dr. Javasri. I thank Dr. Poonam Lamba to be the chief guest, and the guest of honors who has accepted is Dr. Pranay, Dr. Revati, and Dr. Vidya Prabhakar. She is the TNFUG, president of ABBA, Tamil Nadu. And we have two sessions, one session being the investigations of anemia by Dr. Saravana Kumar. He is the treasurer of TNFUG, and President of Salem Society. And we have the panel discussion of the case scenarios, which will be moderated by me and with Dr. Madan Kamble and Dr. Aditya Garg. He will be joining within half an hour, I think. And the panelists being Dr. Priya Kadam, Dr. Vandana Kanti, Dr. Kirana Silvi, Dr. Alagu Sakti, Dr. Tilai Nachia, Dr. Jayalakshmi, and Dr. Sadhana Devi. And I thank our MOC, Dr. Madhumita and Radhika for coordinating this program. So first, we'd like to introduce our Dr. Pranay sir. Dr. Pranay is the professor of Assam Medical College, Dibrugarh, and teacher of UG and PG for more than 35 years. He is an examiner and a Foxy ICOG visiting professor 2015 and 16. AO for Young Gynecologist Awardee in 2002, trained in Boston, USA in infertility. President Dibrugarh since 2022 and Secretary Dibrugarh since 2021 and President ISOPAP. He has more publications and a special interest in infertility and endometriosis. And he has many chapters in many books and chief editor of Handbook of Infertility for Practitioners published in 2021. Welcome, Dr. Pranay, sir, and we need the blessings of you.
Namaskar.
Welcome, sir. Dr. Pranay, sir, is president of Dibrugarh. Sir, my son is also in Boston. So we want to wish this webinar.
Okay.
Yes, sir.
Yes. Yeah. Thank you, ma'am, for the introduction and giving me this opportunity to join you.
Sure, sir.
Yeah, your topic is actually too important for our part of the country, where we have a lot of maternal death and morbidity due to anemia in pregnancy. This is a beautiful topic that I've selected, and then I wish you all the best. And then I think that everybody will be enjoying, and then we will get a lot of information from this beautiful academic fest. Thank you very much.
Thank you so much, sir, Dr. Pranay, sir. Then I welcome our own TNFOG President, Dr. Vidya Prabhakar, CV. Vidya Prabhakar, Madam, is the President of TNFOG and past President of OG Society, Salem.
Yeah, thank you, ma'am.
Madam
Thank
is infertility specialist and the recipient of Foxy Dira Award, and in many conferences, she is the speaker. Yes, Madam.
Yeah, thank you very much, Sampath ma'am, for this kind introduction and for inviting me today as the guest of honor for this wonderful program, North, East, West, South. So Pinnacle News program, which is having equal representation from everywhere. And I welcome all the societies, and I'm happy to be here today because the topic is actually very close to my heart because I'm very much into high-risk pregnancy. And what I find is that nowadays everybody is into all sorts of latest topics and the trending ones. Okay, but nobody is actually paying too much attention to anemia, which is one of the basic problems and one of the major problems in pregnancy. And I'm very happy that we are dealing with that today because an understanding of anemia will save many a life, many a mother. Thank you very much.
Thank
and
you,
I
Madam.
wish this conference and wish this webinar all success.
Thank you, Madam. Thank you so much for the nice words. And I think Dr. Revati and Dr. Poonam Lamba has not joined. We will start with the scientific session.
Yes, ma'am.
So the first scientific session being the investigations of anemia by Dr. Saravana Kumar. Saravana Kumar, CV, please.
Ma'am, Chairperson CV.
Chairperson,
Dr. Madhumita?
Kavita. Yes, ma'am.
Dr. Kavita, are you there?
No, ma'am. Kavita ma'am has not
Not
joined.
joined.
Not joined, ma'am. Davashri ma'am, I think she's joined. Davashri ma'am?
Yes. Mm.
Yes, ma'am. Davashri ma'am, I'll introduce her.
Good evening. Good evening, ma'am. Good evening, everyone.
Welcome, Dr. Davashri.
It's my
Good evening,
pleasure.
ma'am.
Good
Yes.
evening. It's my pleasure to introduce Davashri ma'am, who's currently the secretary of Salem Society of Obstetrics and Gynecology, and she's a consultant at SKS Hospital, and she's also the clinical director at Vriksham by SKS Fertility Unit, and she's a fellow of European Board of Obstetrics and Gynecology, and she's heading the high-risk obstetric unit at SKS Hospital, and her interests are fertility enhancing gynec laparoscopy and fertility, and is a passionate mentor to teach doctors to become members of Royal College and European Board. Welcome, ma'am. Over to you to introduce, sir.
Thank you everyone for this very nice opportunity and meet you all here. And so it's my pleasure to introduce my own secretary, my own president, Dr. Saramana Kumar. Most of us know him, but he is a very nice, humble person. He did his MBBS from Bellary and MD from MMC Chennai. And he presently he is the president. Sir, let everyone know, sir, the president of OG Society Salem, and he's the recipient of the Foxy Dira Award. So over to you, sir.
Sorry for the very poor lighting. I think I will be visible only if I open my mouth and show my teeth. I'll just share my screen.
Yes,
This investigations for anemia in pregnancy is a very important topic. Just a minute. Okay.
Yes,
So
sir. Visible.
Is it visible?
Yes, sir. Yes, sir.
Okay. So I'll just stick on to the investigations for anemia and pregnancy. We know, as Madam told, Vidya Madam told, that it's a very important topic, and we very frequently encounter anemia in our practice because majority of our women are anemic, whatever class they come from. There is poor socioeconomic status, higher socioeconomic status. Everybody are to some extent anemic in our country. And according to WHO, about 32 million pregnant women suffer from anemia worldwide, of which 0.8 million women are severely anemic. Moreover, 50% cases of anemia are attributed to iron deficiency anemia. That's a major problem. And it is projected that India has the utmost prevalence of anemia, that is 57 to 96% among the South Asian countries. We know we are the fifth largest economy in the world. Despite being a fifth largest economy, we see that our pregnant women does not compare better than our other counterparts, either Bangladesh or Sri Lanka or Pakistan. We are all still anemic. Our patients are still anemic to a larger extent. So it's estimated that in India, almost 20% of the maternal death are directly due to anemia, and another 20% of anemia is a contributory factor. This is by this Dr. Ramchandran and Prema, who did a multi-pronged integrated intervention of anemia management, and that is published in 2021. So almost 40% of maternal mortality can be directly or indirectly reduced by correcting the anemia. And this is our NFHS 4 and 5 data, where we are seeing that there is no improvement in the prevalence of anemia among the women, among the pregnant women from NHS 4 and National Family Health Survey 5. That is, it is still the same, or in fact, it has increased 50 to 52%. So why is this Indian scenario like this? We all know that it's because of the socioeconomic status is one thing. The other thing is a high parity, and high parity when we see that our areas, especially South India, Karnataka, Tamil Nadu, we all have come to a total fertility rate almost not in almost less than 1.5. Telangana, Kerala, but still, what happens is in our patients, though they limit their children to 2, they undergo abortions, repeated abortions. So in between pregnancies, they may not take proper family planning measures, and they may undergo abortions. That is another problem. Nutritional deficiencies, yes, that is very, very prevalent in our places because we do not take proper heme iron. And what I see is our people have so much of food fats, especially in our places. We have this Puratasi, Shravana Masa in Karnataka. In North India, they have this Navaratri, all those time where they limit their protein intake. The globin is also less, and also the amount of the iron which is absorbed through the other means, that is vegetable sources, are very less. The other thing is phytate-rich iron diets, malaria, helminthic inflammatory diseases, and certain regional prevalence of hemolytic anemia. It's not that we are not having hemolytic anemias. Yes, there are some certain pockets in India where we have a very high incidence of hemoglobinopathies. So taking all these things into consideration, a small recollecting of the physiological changes, what we see is there is a gradual increase in the blood volume by 6 weeks of gestation. As we all know, this is a physiological anemia of pregnancy. The plasma volume continues to rise subsequently and reaches a plateau of around 32 to 34 weeks. But then the RBC volume takes a very small step and it increases by around 18 to 25%, and it reaches its maximum at 36 weeks. So what happens is there is hemodilution, and this hemodilution, as we know, is very, very essential to reduce the viscosity of the blood, and this blood has to surge in between the papillary circulation of the placenta. That is one thing. The other thing is, it is not just the maternal RBC expansion that is utilizing the iron. There are so many other things like myoglobin. There is the cytochromes which are an important component of ATP, and this ATP is very much essential for the fetal growth, especially fetal organ growth like brain growth. So organogenesis also utilizes certain cytochromes which are dependent on iron, and so these patients can have a very high requirement of iron, especially 4 to 5 grams, 5 milligram per deciliter per day requirement. And if the placenta, when we see the repeated pregnancies and the placenta itself is going to harbor around 250 milligram of iron, which is going to be lost every pregnancy. So there are some alterations in the complete blood count which happens during the pregnancy. That is, hematocrit is reduced, the hemoglobin values are reduced, and the RBC count is reduced in cases of hemodilution. Whereas certain parameters like MCH, MCHV, and mean corpuscular hemoglobin, all these three are usually static. So they don't reach a lower level unless until the patient falls anemic. The other thing which we see is sometimes we may be mistaking the reticulocytes. Reticulocytosis may be mistaken for a macrocytes. So these can be diagnosed only if we do a vital staining. So these are the hematological changes while we see the blood volume or the plasma volume increasing to a rapid extent around 40 to 50%. The RBC volume is a very slow progress and it increases to 20 to 20%. And this causes the hematocrit to fall to around 20% here. So when we consider iron deficiency anemia, it is said that it accounts for around 75% of anemias in pregnancy. So though we consider iron deficiency anemia is very common, and we majority what we do is we treat the hemoglobin of the patient. We don't treat the patient as a whole. So many times when the patient comes to us, we see that the hemoglobin is 10 grams, 9 grams. We treat according to that, and sometimes we miss some things which is beyond iron deficiency anemia. So pregnancy significantly increases the daily iron requirements due to several reasons. So this is a study done by Ritesh and Dadevar, who told that the prevalence of iron deficiency anemia in the study population in Pune is somewhere around 66%. And when we see the rural-urban divide, that is around 81% of rural population has got an anemia, and urban population is 51%. And the prevalence of iron deficiency anemia is still around 54% in primary gravidas. So primary gravidas, even though they are having this first pregnancy, they still have iron deficiency anemia, reported almost half of the patients. And why do these patients have this sort of anemia? Almost 90% of the participants in this trial, where they're thinking why these patients become anemic in spite of providing iron tablets, they did not take their iron supplements as directed. So maybe because of deficient supplies, or because they were not able to complete due to forgetfulness, due to adverse effects like constipation, gastritis, many women refused to maintain consistency. So Tamil Nadu government, what they do is majority of our patients who go to a PHCs, they give them almost 4 iron sucrose injections. Almost every patient receives the iron sucrose injections in the second trimester. I think that is a very good strategy to improve the iron status of these patients. So when we see the normal blood values in the pregnant women and the non-pregnant women, we see the hemoglobin count to be around 11 to 14 grams. RBC count is reduced from 5 million, it is going to 4 million. Whereas MCV, MCH, and MCHC, these 3 parameters are almost the same in the non-pregnant as well as in the second half of pregnancy. Only when these parameters are going to come down, we are going to diagnose anemia. Serum iron, almost it is also the same, except for the higher limit. Total iron binding capacity slightly increase in the total iron binding capacity, and saturation percentage is becoming less in the second half of pregnancy. Serum ferritin levels, almost that is also coming half in the second half of pregnancy. But these are the things, the iron parameters is not done as a routine, whereas we do a complete blood count for the patients who come to us in the first visit itself. So if we analyze the patient with a complete blood count, even though her hemoglobin may not be showing us levels of less than 11 grams, from the complete blood count, we will be able to decide whether this patient is falling anemic or not. So the clinical suspicion of anemia should be confirmed by complete blood count. So if we consider a complete blood count in the first visits itself, we can classify anemia using the type of MCV, that is whether it is a normocytic anemia, microcytic anemia, or a macrocytic anemia. Once we classify this sort of anemia based on the MCV, we will be able to cover almost all the anemia other than the iron deficiency anemia. So for microcytic anemias, we will see iron deficiency anemia as well as thalassemia if the MCV is less. Whereas in case of normocytic anemia, it can be hemolytic anemia and non-hemolytic anemia. So hemolytic anemia can be microangiopathic hemolytic anemias, which can be thrombotic thrombocytopenic purpura, hemolytic uremic syndrome, and HELP syndrome. Whereas non-microangiopathic hemolytic anemias may be non-immune mediated, that is intrinsic RBC disorders like sickle cell disease, membranopathy like hereditary spherocytosis, and PNH. So the non-hemolytic anemias may be physiological anemia of pregnancy, anemia of chronic disease. This is sometimes very much missed in our patients. Bone marrow aplasia is a very rare cause. Then comes the macrocytic anemia. There are only two causes for macrocytic anemias: vitamin B12 deficiency and folic acid deficiency. And these may not be overtly visible also, but only if we take a proper history from the patient. Patient may be suffering from some celiac screw, or their gastric resection might have been done, or other causes for B12 deficiency may be there, or the patient may be taking some anticonvulsants, which are not directly related to B12 and folic acid deficiency. They act in a different manner. So they also can cause macrocytic anemia. The other thing is anemia associated with other organ dysfunction. For example, hypothyroidism and chronic liver disease. So the causes for iron deficiency anemia, as we discussed previously, may be other things like celiac disease, inflammatory bowel disease, gastric bypass, and concomitant other drug use, apart from twin gestation hyperemesis, where the demand is increased for the patient. So we will stick on to the standard definition of hemoglobin levels to diagnose anemia: mild, moderate, severe, and very severe. There are 2 or 3 classifications: WHO classification, RCOG classification, and some say Mudliar classification. But this is what is uniformly practiced. ICMR classification: mild anemia is 10 to 10.9, moderate anemia is 7 to 10, and severe anemia is less than 7, and very severe anemia is less than 4. So though we see this our patients coming up with moderate and severe anemia, and we give them blood transfusion and sometimes iron injections also, many times what we forget to see is what is the underlying cause for anemia. We always think that it is only iron deficiency anemia and treat with iron sucrose. In spite of giving iron sucrose, in spite of treating them with blood transfusion, some patients may still remain repeatedly anemic, and there lies that we have to do the other investigations for these patients. Some of the definitions are: mean corpuscular volume is the measure of the average volume of RBCs and not the diameter of the RBCs. Mean corpuscular hemoglobin, average weight of hemoglobin in individual erythrocytes. So it is denoted in picograms. Mean corpuscular hemoglobin concentration is the average concentration of hemoglobin in the erythrocytes as a percentage. And red cell distribution width, that is a measure of the variability of the erythrocyte size. That is, the size may vary by microcytic anemia or macrocytic anemia, or it may be a dimorphic anemia. It all depends upon the type of anemia and its treatment. Sometimes the treatment may also influence the patient's. So that may be represented by the red cell distribution width, where the red cell might be a smaller as well as the larger cells. So this is a very important slide where we will be able to see that hemoglobin levels are still 11 grams and it is not anemic, where the storage iron and the transport iron is completely depleted. Almost the storage iron is lost, but still the hemoglobin levels is 11 grams. If we consider the storage iron and the transport iron is almost present in a normal person, we see that the mean corpuscular volume is normal, 80 to 100 femtoliters. Whereas when the storage iron is lost, this area of iron depletion, we see that the first thing which happens is the mean corpuscular volume, it decreases, and red cell distribution width, that increases. So these two are the important parameters which can tell us that the patient is still anemic despite the hemoglobin level being normal and the iron levels almost becoming normal. So his plasma iron is still normal, but the patient is anemic because of the loss of storage iron. Again, when there is iron deficient erythropoiesis, so the transport and functional iron is also lost, and almost 50% of the transport and functional iron is lost. In those conditions, we are able to see that still the MCV is reduced, the red cell distribution width is increased, and the plasma ferritin levels, that is the storage level of iron, is becoming very low. And here we will be able to see that the plasma iron is also becoming reduced. But in spite of all these things happening in this patient, hemoglobin still is 11. So we see majority of our patients in this category where they are iron deficient erythropoiesis, iron depletion is there from the storage iron. Transport and functional iron is also almost less than 50%. And these are the patients who require to be early diagnosed with iron deficiency anemia and treated. And when the patient presents to us with less than 11 grams, all these parameters are deranged. So I'm not going to details of the iron absorption. What we see is hepcidin is one hormone, one enzyme, which may reduce the amount of iron absorption if repeated iron tablets are taken. So the plasma iron may still be normal, but the storage iron might be lost. And that is an indirect method of hepcidin acting on the absorption methods, which can reduce the amount of iron absorption if the patient is taking more of iron rather than properly diagnosing what is happening for the patient. So now the primary step in the diagnosis of iron deficiency anemia is to consider the complete blood count, including hemoglobin, mean corpuscular volume, mean corpuscular hemoglobin concentration, and MCH. Along with the peripheral smear is what is required for a patient who comes to us initially with an anemia. When we see that the hemoglobin level is less than 11 grams, we do a peripheral smear along with this complete blood count. We will be able to almost diagnose the type of anemia for this patient. It is very simple, inexpensive, rapid to perform, and helpful for prediction of iron deficiency anemia. So when we consider mean corpuscular volume and red cell distribution width, 40% of patients with true iron deficiency anemia will have a normocytic erythrocytes. That is, normal NCV does not rule out iron deficiency anemia, but what we see is red cell distribution has got a better sensitivity than MCV for the diagnosis of iron deficiency anemia. So this study tells red cell distribution width has a sensitivity of 82% and a high specificity, whereas MCV, MCH, MCHC has got very low sensitivity, but specificity is very high. So iron deficiency anemia without other complicating diseases could be screened out early by increased red cell distribution width when RBC indices are still normal. So this is another slide which tells about the correlation between the MCV and the red cell distribution width. So if the mean corpuscular volume is less than 80 femtoliters, microcytic, red cell distribution width is less than 15, that is, there is no difference. All RBCs are almost the same. It means that it is microcytic and there is no amount of other type of red cells. So it may be anemia of chronic disease like thalassemia, sideroblastic anemia. All these conditions, iron is still retained. The RBCs might be broken down, but still the iron is consumed for the other RBCs to be formed. So the RBC count is not reduced and the red cell distribution width is normal. Whereas in case of iron deficiency anemia, we see that the MCV is less than 80 femtoliters, that is microcytic, but there is a whole array of RBCs which may be small sized, large sized, and the RBCs which are which are coming out of the bone marrow due to the presence of iron supplementation. So a sort of dimorphic anemia. The other condition is MCV is more and the red cell distribution width is still normal. That means majority of the cells are macrocytic. That happens in vitamin B12 or folic acid deficiency. And red cell the MCV is more and the red cell distribution width is normal. Happens in liver diseases, alcoholism, and aplastic or hypoplastic anemia. If the MCV is also of the normal range, RDW is also on the normal range, then it can be anemia for chronic disease or maybe because of hemolytic anemias. So what are the lab tests used to diagnose iron deficiency anemia? So as we saw, we all can do red cell parameters and the indices, RBC indices and the parameters, and direct measurement of iron stores. These are the two things which can be done in our laboratory. Assessment of heme ion, assessment of ion uptake is in an experimental stage. So direct measure of ion stores, we can do the assessment of serum ion binding capacity, serum ferritin. Assessment of heme ion can be done, which is the storage ion, estimation of free erythrocyte protoporphyrin, and assessment of ion uptake can be done measuring the soluble serum transferrin receptor and soluble transferrin receptor log index and zinc protoporphyrin. So all these are not done as a routine, very costly, that is very costly lab investigations, and used only in sets of, in cases where the patients are undergoing any of these studies. So blood values, what happens in iron deficiency anemia, serum iron level is less than 30 microgram, total iron binding capacity is raised, that is the RBCs want whatever anemia, whatever iron is available to be absorbed, that is iron binding capacity is raised by more than 400 microgram per deciliter. Percentage saturation of iron is less than 10%. Serum ferritin becomes less than 30 microgram per liter. Bilirubin is not raised, which indicates that that is not a hemolytic anemia. Hematocrit may be less than 33%. Mean corpuscular volume, MCV, is less than 79 or less than 80 femtoliters. Transferrin saturation is less than 60%. And if a bone marrow biopsy is done, there is lack of stained iron in the macrophages and in erythroid precursors. So what are the limitations of RBC indices? So though we know that RBC indices can be used as a screening technique, the test is very cost effective and it is simple, but it has got its own limitations, such as it is a screening test and it's not a diagnostic test. MCV is not reliable when anisocytosis is present, especially when there is a dimorphic anemia or both iron deficiency anemia as well as folate deficiency anemia. Then this does not become very reliable, and it is also does not reflect the diameter of the RBCs. It's a volume of the RBC. There may be false high or low value which can be evaluated further. So automated reticulocyte count is not standardized yet, and manual method has got inter-observer bias, and these reticulocytes can be mistaken for RBC, that is an increased MCV. So these are the newer diagnostic tools for iron deficiency anemia, that is soluble transferrin receptors, reticulocyte hemoglobin content, which can be either a direct concentration of hemoglobin in the reticulocytes, or it can be hemoglobin equivalent. But the problem with these investigations is these are costlier, but it may reflect the amount of erythropoiesis as well as the amount of storage iron, especially reticulocyte hemoglobin content. They are introduced, but maybe having a very limited utility, and especially it is useful only for experimental purposes. So this is another Menzer index, as we were discussing about iron deficiency anemia as well as hereditary spherocytosis, which both come under microcytic anemia, that is MCV less than 80 femtoliters. Here we see that the Menzer index is a MCV divided by RBC count. So that is, it gives a very rough estimation whether it can be an iron deficiency anemia or it is a thalassemia. Because in thalassemia, what happens is the RBCs are small, but it's also there's a normal or high number of them. So the low MCV divided by the normal RBCs produces a ratio less than 13. So in iron deficiency anemia, what happens is the RBCs are also low and they are also small. So the total RBC count is less. So the MCV is divided by low RBC count, results in a higher ratio that is more than 13. So this is a very simple test which can differentiate between the iron deficiency anemia as well as thalassemia. But still, sometimes after getting this account, we have to do electrophoresis to know about the patient is really suffering from iron deficiency anemia or a thalassemia. Coming to macrocytic anemias, I told you that the macrocytic anemia may be because of vitamin B12 deficiency as well as folic acid deficiency. So here we see that the MCV is elevated and the characteristic blood film features are oval macrocytes, hypersegmented neutrophils, Howell-Jolly bodies, thrombocytopenia, red cell fragments, teardrop cells, giant polymorphs, and megaloblasts. So typical pictures, not all may be present, but many of these things may be present in a peripheral smear. So having a peripheral smear may give us an idea about whether this patient is having a macrocytic anemia or dimorphic anemia, iron deficiency anemia. So this can be a very simple test to have as a screening for the patient. Whether to do B12 measurement or a folic acid measurement, is usually not required unless until we get a very good history from the patient. Some of these patients may be totally vegan. They may not be even taking milk. So vitamin B12 is available in vegetables, in animal sources to a larger extent. And unless until the patient is having some sort of gastric problem, or if the patient is totally against taking any animal products, these are the patients which may be falling short of B12, B12 deficiency, and they may be having other symptoms also, like they may be having demyelination problems also. But these are the patients who get very well cured, especially by giving a B12 injection. One B12 injection itself is going to help the patient to recover from her losses. Again, folic acid deficiency is very common because of the lack of folic acid, especially the antifoliates present in our food, and it is commonly seen. But the differentiation between the folic acid deficiency and B12 deficiency here is B12 deficiency leads to an increase in the level of methylmalonic acid and homocysteine levels, whereas folic acid deficiency will increase only homocysteine levels. So the normal folate values are 2.8 to 8 nanogram. Deficiency level is less than 3 nanogram per ml, and normal B12 values are 300 picograms per ml, and deficiency is less than 90 picogram per ml. These are not routinely used, but can be used in cases of refractory anemia where we are not able to ascertain if the patient is having an iron deficiency anemia or if it is because of B12 deficiency or a folic acid deficiency, where we have given adequate iron supplementation and the patient is not able to improve her status. The other things are the microangiopathic hemolytic anemias, where it is still a normocytic anemia, HELP syndrome, HUS, TTP. These are conditions which can require immediate delivery, and so they are subjected to other investigations which are relevant. For example, in HELP syndrome, we have to do a liver function test, platelet count, and also about to know about the bilirubin levels. Again, HUS, the uremic syndrome, we have to do a creatinine levels, and thrombotic thrombocytopenic purpura, we have to do the platelet count, and that determines the outcome of the patient. So hemoglobinopathies, though we encounter very rarely here, it is seen in many of the areas, pockets in India, and sometimes it is seen many, especially in tribal populations. About 10% of the world's thalassemia patients belong to the Indian subcontinent, and 3.4% of them are carriers. In India, about 32,000 infants are born with hemoglobinopathies every year. So how are we going to diagnose thalassemia and hemoglobinopathies? We see that it is a microcytic hypochromic blood picture in complete blood count and absence of iron deficiency. All the iron parameters, serum ferritin, serum iron, all these things are normal. Then suspect the hemoglobin disorders. The MCB may be less than 78 femtoliters, mean corpuscular hemoglobin less than 27 picograms. But sometimes the peripheral smear may show for abnormal red cells morphology like target cells, stippled cells, sickle cells, nucleated RBCs, and red cell inclusions. All these may indicate that the patient has got one of these hemoglobinopathies. So if we go by RBC indices, MCH is less than 27 picogram, and if the iron deficiency is excluded by the iron parameters, then we can go for electrophoresis, which can help us know if there is HBH bodies, which means that it is alpha thalassemia trait, and if there is HbA2 more than 3.5% in the electrophoresis, that is beta thalassemia trait, and there may be abnormal hemoglobin like hemoglobin S, sickle cell hemoglobin, hemoglobin E, hemoglobin C, which can be detected by the abnormal electrophoresis. So once we diagnose these type of refractory anemias, the entire outlook of the patient and the treatment differs for the patients. So these are some of the different types of RBCs which we see in peripheral smears. This is echinocytes, elliptocytes, which is elliptical, poikilocytes, where there is different types of RBCs. Schistocytes are the Burr cells, sickle cells, and teardrop cells. Dimorphic anemia, where we are able to see hypochromic as well as normochromic. Hypochromic anemia, polychromasia, spirocytes, and abnormality of the size. Anisocytosis, that is different types of RBCs, smaller RBCs as well as larger RBCs, macrocytes, microcytes. Havel-Jolly bodies are inclusions inside the RBCs. Parasitic infections may be there, and punctate basophilia may be there. So one or two slides to tell about some case scenarios. 22-year-old gravid 2 para 1, living 1. Last childbirth 1 year back at 24 weeks. History of tiredness and routine hemoglobin is 9 grams per deciliter. RBC levels is decreased. Mean corpuscular volume is less. Mean corpuscular hemoglobin is also less. Mean corpuscular hemoglobin concentration almost normal. But what we see in the peripheral smear is, we see here smaller RBCs and less color. So microcytic hypochromic anemia, this totally goes with the iron deficiency anemia. Second is, these are common cases. Second is a 25-year-old primate who had 4 doses of iron suppress injections in the second trimester. Repeat hemoglobin after the week of the last iron injection is hemoglobin 9.8 gram per deciliter. RBC volume is almost the same, whereas her MCV, mean corpuscular volume, is raised. Mean corpuscular hemoglobin is 25 picogram. Mean corpuscular hemoglobin concentration is normal. 32 to 40 is the normal. So 32 to 36 is normal. It is still normal. And what we see here is the RBCs are larger, and it is almost, the RBCs are almost equivalent to the WBCs. And what we see in the WBCs is the multilobulated neutrophils. So this is a typical example of macrocytic anemia or a vitamin B12 folate deficiency anemia. So what are the type of cells here? Here we see target cells. There is a central concentration of hemoglobin, a slight pallor surrounding them. So this type of hemoglobin is seen in chronic diseases as well as in cases of thalassemias. This is a common blood picture where we see microcytic anemia as well as we see microcytic hypochromic as well as macrocytic anemia. These are macrocytes and hypochromic anemia. This is a dimorphic anemia where iron as well as folic acid deficiency is seen. Anisopoikilocytosis is where the size of the RBCs is different, the shape of the RBCs is different. We see many teardrop shells here, and schistocytes are seen here. Microcytic anemia is seen. Macrocytes are seen. Macrocytes with normocytic anemia are seen. So this is a anisopoikilocytic blood picture. This is an easy diagnosis. If at all we see these type of cells, that is a sickle cell anemia. So in summary, we have to have a typical complete blood count when we encounter the patient as a screening test, and go for further test if the patient is having a suspicion of iron deficiency anemia. Based on these tests, we can go for iron parameters, serum iron, serum ferritin, and if at all needed, then we can go for the other diagnosis also. So this is the strategy by Government of India to provide Anemia Mukt Bharat, where we are going to give prophylactic iron and folic acid supplementation, deworming, intensified year-round behavioral change, that is including ensuring delayed cord clamping, which happens from the childbirth, testing of anemia using digital methods, and point-of-care treatment. Especially when the patient comes, we are going to do the hemoglobin testing immediately and treat them there. Mandatory provision of iron and folic acid fortified foods in public health programs so that it reaches the very large population, and addressing non-nutritional causes of anemia, especially in endemic pockets, like as I told, some places of Madhya Pradesh, Chhattisgarh, Orissa, where we find these patients who are having hemoglobinopathies and especially fluorosis, which are also common in our country. Thank you. Thank you for the patient listening.
Thank you, sir. Thank you so much, sir. I think.
Thank you, sir.
Ma'am, your comments, ma'am?
Sir, that was a very wonderful, precise, totally, you've just concluded everything into one beautiful presentation. Sir, thank you so much, sir.
That too with the case presentation.
Yes,
Wonderful,
ma'am.
Sarana Kumar. Thank you. Dr. Aditya has joined, I think.
Yes, ma'am.
Yes, sir. Sarana Kumar,
Sure,
thank you. Fantastic talk. This
Thank
will be available in the YouTube. This link will be. I think after the webinar only, many people are visiting at the YouTube. Yes, Madhumita, we will go to the next session.
Yes, ma'am. So moving on to the next session, which is a panel discussion. So we have our moderator, Professor Dr. Sampath Kumari ma'am, and our experts, Dr. Aditya Garg and Madan Kamble sir, and our esteemed panelists.
Then put the panelist CV.
Yes, ma'am. Next, we have our experts, Dr. Aditya Garg, sir. He's a consultant at Garg Maternity and Surgical Center at Ambala, and he's also and sir is also the secretary of Ambala Obstetric and Gynecological Society, and he's ex-consultant fetal-maternal medicine at UK. And we have our next expert.
Second time we are involving Dr. Aditya. He is
Yes,
accepted to come. Okay.
Yes, ma'am. We have Dr. Madan Kamble, sir, who's a consultant obstetric and gynecologist and sexual health expert and aesthetic gynecologist and chairperson of AMOG Sexual Medicine Committee and also national coordinator of Foxy Sexual Health Committee and past
Admita,
secretary and
is
past
having
president.
some emergency. I think he has
Okay,
left.
okay, ma'am.
If free,
Yes, ma'am.
will come and join.
Yes, ma'am.
Okay.
And we have our esteemed panelist, Dr. Kirana Selvi, who's an executive council member of Salem Obstetric and Gynecological Society. Next, we have Dr. Jayalakshmi, who's again the executive council member of Salem Obstetric and Gynecological Society. Dr. Tillai Nachiyar, who's a consultant at SK Hospital at Chennai and also senior assistant professor at Keel Park Medical College. Dr. Alagu Shakti Saubarnika, who's a senior resident at Public Health Center at West Mambala. Yes.
Admita, you left Dr. Sadhana Devi.
Yes, ma'am. The slide.
Sahiti Bari Sadhana Devi is in the
slide.
series, I think. She is an RCOG and she is the consultant.
Yes, and we have Dr. Sadhana Devi, who's a consultant obstetric and gynecologist and fertility specialist at Yogesh Fertility Women's Hospital and Urology Hospital at Chennai. Over to you, ma'am.
Yes, definitely. 1 minute. I'll share my presentation first.
Yes, ma'am.
It's not going to the slideshow. Yes.
I didn't bring mask today. But ma'am told, well, it's okay, you can.
Somebody. Yes, Dr. Aditya. Shall I start? And I welcome all our panelists. I think Dr. Priya Kadam and Vandana Devi didn't join. Kirana Selvi, Jayalakshmi, Alagusekti, Tillai and Sadhana Devi. This is only the practical points which we are doing practically, nothing theory. See, globally, it is estimated that now we had a wonderful talk by Dr. Dharana Kumar. The 40% of all children and 6 to 59, 37% of pregnant women and 30% of women 15 to 49 years have been affected by anemia. As all of us know, it is due to the number of red blood cells and the hemoglobin concentration becoming lower than the normal. So we'll start with Dr. Sadhana Devi. So, Dr. Sadhana, how are you going to classify the anemia in pregnancy?
Pardon, ma'am?
How are you going to classify anemia according to which guidelines in pregnancy?
So WHO classification classifies as anemia into like 3. The first trimester would be less than 11 grams considered as anemia, and second trimester less than 10.5 second and third, and postpartum less than 10 grams per deciliter considered as anemia. Mild, moderate, severe.
Yes, Alagusekti, do you want to tell anything about the classification? You have to unmute. Alagusekti, unmute.
Yes, sir. There's another classification that includes ICMR, in which the same thing comes, but very severe anemia is less than 4 grams per DL. And we can also consider hematocrit of less than 33% also can be considered as anemia in pregnancy.
So, as the hemoglobin and hematocrit is considered as the differentiating anemia. So now we will come to the simple case. All of us will be seeing such a type of cases. 30-year-old gravida 3, 28 weeks, comes to the OP with the complaints of tiredness and difficulty in breathing. Her vitals looks normal. And her abdomen, it corresponds to the gestational age. And FH is also good. On examination, mild pallor is present. So, Dr. Jayalakshmi, if this patient comes to your OP, how are you going to proceed? Dr. Jayalakshmi?
Yes, ma'am. Ma'am, we'll do anemia investigation. To start with, we'll do a complete blood count with the RBC indices. So we'll get to know the hemoglobin, hematocrit, and the RBC indices, MCV, MCH, and MCHC. So that we'll come to know if it is microcytic or macrocytic anemia, depending upon the MCV values. Then we can go on further to proceed with serum ferritin and peripheral.
Dr. Jayalakshmi, or do you do the serum ferritin routinely or only the complete hemogram with smear?
Ma'am, first it is complete hemogram and with the RBC indices. Then if it is hemoglobin less than 9 grams, then to proceed with serum ferritin and smear.
Yes, after the COVID, all of us are starting to do with the serum ferritin. Previously, serum ferritin was not done. Now, any one of you are doing the serum iron, total iron binding capacity for all patients in anemia in pregnancy?
No, ma'am. No, ma'am.
We don't do it, ma'am.
Dr. Kirana Selvi and Dr. Tilay Nachia. So, most of us are not doing. So, we go with the complete hemogram and the peripheral smear. Now, as Jayalakshmi was telling, the other indices was normal. For discussion sake, I have mentioned this alone. The hemoglobin is 9.4 and smear has come as microcytic hypochromic anemia. Now, the patient is 28 weeks. Dr. Kirana Selvi, how are you going to proceed with this patient? Dr. Kirana is there, I think. If she is not there, Dr. Tillai, you can take up.
Good evening, ma'am. She is in second trimester. So already it's in the mild hemoglobin, mild anemic. So we have to treat as parenteral. We can go for parenteral iron therapy. Like usually we are giving in PHC, primary health center, total dose of iron we have to calculate, and as per the total dose, we can go for iron sucrose injection, either 5 doses of iron sucrose injections. So it will improve the hemoglobin level.
Okay. Dr. Alagasakti, do you go with the parenteral or what do you do in your peripheral center, ma'am?
She's 28 weeks with a hemoglobin of 9.4, which comes under mild anemia. I will confirm whether she's taking iron tablets properly first, whether she's compliant to iron tablets, and I'll also confirm whether she has been given deworming and things. And I'll probably give her with oral irons, ma'am. She's mild anemia, and I'll go for with oral iron.
Okay. Dr. Jayalakshmi?
Dr. Sampath Kumari.
Yes, Dr. Aditya. Yes, Dr. Pranay, sir. Yes, sir.
Can I say something that
yes, sir,
definitely. Before going for any parenteral therapy, should you see the serum ferritin as well as the hemoglobin typing? Should you do you normally do it, hemoglobin electrophoresis?
No. In our place in Tamil Nadu, we are not doing electrophoresis. Normally, the Menser index and the serum ferritin, as a panelist was doing. Even in the government hospital setup, electrophoresis is not available, sir.
Okay. If the serum ferritin is a normal level and then still sees anemic, then what do you do then?
We will, Tilenachar, you can tell what are you doing in the KMC to differentiate it. Normally, we proceed with the Menser's index and the serum ferritin and RDW.
Okay. If it is microcytic hypochromic, means it's iron deficiency anemia. We have to correct the iron either form of oral or parenteral. So oral iron already we are starting in the early second trimester at 16 weeks, 14 to 16 weeks. We are starting 100 tablets in the peripheral setup itself. We are advising, and the oral tablet is still not improving. At the end of second trimester, we'll advise parenteral iron therapy.
Okay. Dr. Aditya, what is your opinion? Dr. Aditya? So, no, he is not there. So, Dr. Sadhana Devi.
No, I'm here.
Yes, what is your opinion? So, they are.
Ma'am, I normally start all my patients on iron tablets, regardless of their HB. In North India, people are kind of severely anemic, and most North Indians are vegans. They don't even eat egg. So, especially in females. So you normally will find that even if the HB is around 10, 11, they will still all be microcytic in their PBFs. So what I normally do is I do an HPLC in all my patients because in a lot of North Indians are carriers of HBD Punjab as well, other than routine thalassemia mutations. So basically, after that, you get a good enough picture, and then I start all my patients on oral iron. On anyone who has got difficulty in breathing, we actually need her to build up her iron reserves faster. So in this case, I would probably agree that if she's already on iron tablets, then I'll start her on parenteral iron or give her a dose of parenteral iron. And nowadays, we are using FCN more often than iron sucrose.
Are you using FCM?
Ma'am, it's meant to be a safer drug, and you can give a total dose infusion in one go rather than calling the patient 2 or 3 times.
Multiple dose. Okay.
So that's the main reason.
As Pranay sir was asking, do you do the electrophoresis and how will you differentiate the thalassemia?
Ma'am, I do electrophoresis on all my patients now. And yeah, electrophoresis means they will tell us the levels of HbA and HbA2 and HbF. So that differentiates between the type of mutations that we are looking at. If it's sickle cell, then HbS will be more. If it's a thalassemia carrier, HbA2 will be increased. And after if you do find a carrier, then the next step should be to offer her a genetic analysis of her thalassemia gene to know what mutation she's carrying. But you can obviously, you'll need to check the husband first. And if only one of them is a carrier, then you don't need to do anything else.
Okay, that facility. So electrophoresis you are having, but in the government hospital setup, we don't have. Anyway, it's nice to do to differentiate it from the thalassemia. So as all of us were telling, 28 weeks, microcytic hypochromia, first you die with the oral. And if she is not tolerant to the oral and if she is not willing, then you go with the parenteral iron. So the prophylaxis dose already Dr. Atile has told that is 60 milligram. Normally we go with the 100 milligram elephantal iron for 100 days, preferably in the second trimester, late second and the third trimester. So parenteral iron, how are you going to proceed with this parenteral iron, Dr. Sadhana Devi? How are you going to give this parenteral, whether it is sucrose or FCM?
In government hospitals, we administer iron sucrose injections. Nowadays, in peripheral, in private setups, we do resort to ferric carboxymaltose, FCM preparations. Since
What is
the
dose
volume
you
of
give with how many, within what is the duration, how many doses you give within a week?
So maximum is 3 doses per week. Alternate days, maximum 3 doses per week, 100 milligram. Iron dextran, we were earlier using in setups. Nowadays, we have moved to iron sucrose injections in the form of
Yes, you proceed.
Yes. So iron sucrose injections in 100 ml NS, we usually administer on alternate days. Maximum is 2 to 3 doses per week until the until this thing is corrected. Then after 2 to 3 weeks, we usually check the increase in hemoglobin levels. And since the compliance is well met out, usually we see a rise of hemoglobin above 1 to 2 grams after 2 weeks.
So how will you know that your iron sucrose has worked? You have to wait for 3 weeks, no?
Yes, madam. Usually we wait for 2 to 3 weeks and see the rise in the hemoglobin levels.
So the complaints, patients' complaints about that tiredness, everything would have. Do you go with the iron tablet when you are giving iron sucrose? If you are not giving, what is the reason?
We usually ask the patient to refrain from iron tablets the day of administration, prior day, and the next day usually, since the receptors will be filled with it. So we usually tell the patient that to refrain from iron tablets for 2 days, prior to and after that.
So normally this, when you give with the IV iron sucrose, there is no necessity to give the oral. At least for a week also it is better. So Aditya, how will you counsel? If you are going to give the IV iron, do you go continue the oral or not? Aditya, you have to unmute.
Ma'am, I have noticed that there are a lot of GI side effects if you give parenteral iron and oral iron together. But after about a week or so, it really does not matter. and it is best to give a low dose of oral iron along with parenteral. It is quicker to rise. The HB is quicker to rise that way.
Yes.
But that's my personal practice. I think textbooks mention that if you've given parenteral iron, then oral iron can be withheld.
So in our places, we at least don't give the oral for a week. After that, we will continue because the patient will forget and they will not take the tablet. So this is the way, as she told, normal range 100 to 200 milligram iron sucrose will be given. That is dissolved in the 200 ml of normal saline and gives fastly. So what are all the indications for IV iron? Dr. Tillai, are you there? Can you just read it for the sake of audience?
Patient parenteral iron indications.
Yes, parenteral iron.
Yeah, patient is not tolerable for oral irons. Patient non-compliance, inability to take the oral iron. So, and severe anemia in late second trimester and third trimester, and malabsorption.
No, severe anemia, do you go with the IV iron? You go with the transfusion, no? Severe anemia.
Yes, ma'am. Late second trimester.
That is
late second trimester.
Transfusion means you go with the severe anemia only.
Yes, ma'am. Yes,
so, what are all the advantages? Previously, we were giving iron dextran, no? When I was house surgeon, we used to give the iron dextran. Now, why we have moved to the sucrose?
Because iron dextran causes it's IM. It's more painful and it causes pus abscess in the cavity and more strain. Iron strain will cause that gluteal abscess. So, but this iron sucrose injection does not have that much complications like iron dextran injection.
Do you go with the test dose or directly the 200 milligram total dose?
Initially, we'll go for slow. Actually, iron sucrose 200 milligram and 100 ml NS over 20 to 30 minutes. Initially, for 5 minutes, we'll go for slow IV. And then if no reactions means we can give with 20 to 30 minutes.
Yes, that is the routine procedure. Are any one of you giving the test dose? Dr. Aditya, do you go with the test dose and go with the, or as she told, first you go it slowly and then you continue that dose if there is no reaction?
No, ma'am, that is my practice. I just give the first 15-20 minutes slow, and you can use the same drug to continue faster once the patient is stable.
Yes, that is the way FCM, as you told, if the patient is affordable, you go with the ferric carboxymaltose, that is 1000 milligram or 2000, depending on the severity of the anemia. So this formula, this is for the PG sake we are mentioning. So how will you calculate for easy calculation? Suppose the hemoglobin is 8 gram and you want to calculate the dose, means the simple method rather than remembering this formula. Any one of you? See, normally what we do now, I used to tell my PGs the same things. The 250 milligram per 1 gram rise of the hemoglobin. Suppose the hemoglobin is 9 gram as this patient, we need 5. 5 into 250, 1250 milligram. So if you are not able to calculate this dose, 250 milligram per 1 gram rise of the hemoglobin will be easier. Any confusion? Tillai?
Yes, ma'am. Rice, ma'am. Rice.
So that is easier way to remember. So if you don't remember means, so 8 gram means 14 to 8, you minus it and divide into, multiply into 250 and calculate the total dose as we need 600 milligram per week. So that is the normal way we advise for the patient. So how will you differentiate this microcytic anemia? Already we have discussed that Saravana Kumar has already told. Dr. Jayalakshmi, how it suppose the picture comes as a microcytic hypothalamic anemia. And when will you consider that this is a case of thalassemia or you will go with the oral iron itself? Dr. Jayalakshmi, are you there?
We can calculate the Menser index to differentiate between thalassemia and iron deficiency anemia, which is the mean corpuscular volume divided by the RBC count. When it is more than 13, it is iron deficiency anemia. Less than 13, it is thalassemia. So with that, we'll be able to know if it is iron deficiency, we can go with iron replenishment.
Jayalakshmi, do you screen thalassemia before pregnancy? That is the preconceptional care. Do you screen thalassemia in your place?
No, ma'am, not for all patients, ma'am. When the serum ferritin is normal and still the patient hemoglobin is low, and if she has had many times with the hemoglobin of 8 grams, 7 grams, then we do suspect something, there could be a problem like thalassemia. So in that case, we can go for HbA.
Yes. Aditya, do you screen the thalassemia before conception?
Ma'am,
All
any patient who comes to me for preconception counseling or infertility patient, I always do a HPLC. That is my routine practice, ma'am.
Yes, now the thalassemia screening is done even in the government hospitals, but they don't do routinely for all patients. If the patient who comes and they are willing, means that it is better to screen the thalassemia preconceptionally before pregnancy. It will be easier. So then we can do for the husband. So this is, all of you have told this, microcytic hypochromic anemia, see the serum ferritin, if it is low, iron deficiency anemia. Normal means, as everyone was telling, you do with the electrophoresis, and if it is abnormal, consider it as a thalassemia. This is the MCV less than 80 and more than 80. If it is more than 90 means, we can consider as the B12 deficiency. These are all the routine iron deficiency anemia, inflammation, thalassemia, and sideroblastic. How are you going to differentiate with the serum iron, total iron binding capacity, saturation, and the serum ferritin? So deworming. Dr. Alagasakti, do you do the deworming for all patients in your health center, Mambala?
Yes, ma'am. Ma'am, we do routinely in the second trimester, we give 400 milligram of albendazole, ma'am. Routinely we give.
Any one of you are giving mebendazole? Only albendazole or mebendazole is given?
Only albendazole.
Only albendazole. Aditya?
Ma'am, I hardly ever use it, but again, the type of patients I get in my clinic are vastly different from those who will benefit from albendazole. But if a patient is not responding to oral iron treatment, it is worthwhile giving every patient a dose of albendazole. It is not going to harm anything.
So better. So this is the albendazole is that is to be given for all patients routinely. The Tamil Nadu government is giving, whether it is for primary health center or whatever it is, in the second trimester preferably. So now we will go with the complications of anemia in pregnancy. I think we can start with Alagasakti. Alagu, what are all the antepartum complications? And during labor and postnatal, we will go. What are all the antepartum complications you see?
The antenatal complications will start from poor weight gain. The patient may have increased risk of preterm delivery, and they may risk of preterm ruptures, infection. She's prone for preeclampsia, and there is also risk for congestive heart failure if the anemia is untreated. These are the antepartum complications. Intrapartum complications, again, we can suspect postpartum hemorrhage. Also, she can go for congestive cardiac failure, and there will be prolonged.
Intrapartum complication, what you tell about the postpartum hemorrhage?
Sorry, ma'am, prolonged, sorry, it comes postpartum. So it can be a prolonged labor also. Sometimes there will be abruption, very rare cases also. Postpartum, we can have postpartum hemorrhage, and we can have puerperal sepsis, and there can be also lactation failure in the women, ma'am. These are some of the complications we expect in anemia.
See, one patient, suppose anemia treated patient, talking irrelevantly in the postnatal ward, that is on the second or third day. What do you think first?
Corrected sinus thrombosis first.
Yes. So always anemia corrected patient talking irrelevantly in the postnatal ward means don't always diagnose it as postpartum depression. It can be due to the thrombosis. So we have missed one patient also. So always think about the thrombus and the embolism problems in the anemia corrected patient. So what is the complications with the baby? Dr. Tillai?
Yes, ma'am. Baby, low birth weight, IUGR, and sepsis, early sepsis, and hyperbilirubinemia.
So there is a possibility for schizophrenia also. So these are all the routine complications. Other than that, practically, do you have any complications, Dr. Aditya?
No, ma'am. The list is pretty exhaustive. I've not seen this much, but the only thing is if a patient is already anemic at the time of delivery, then even a normal blood loss during labor would manifest as a PPH. I mean,
Yes.
she's got less reserves to lose during delivery.
Yes, that is the problem. Many times the lactation failure, the anemia is missed. If the patient is anemic, there may be near lactation. So we will tell the patient is not feeding, not feeding. Always correct the anemia in the case of the lactation who is complaining that not able to feed. So these are all the complications which everyone we have discussed. So whatever may be the treatment, the iron-rich diet should be counseled for all the patients. Whether it is first trimester or second trimester, once the vomiting is not there, this iron-rich diet is always better. So this is the flow chart, less than 11. Do the, as all of you told, the complete hemogram and see the smear. And if it is hemoglobin is less than 4, consider with severe anemia and transfuse. And depending on this, you classify if it is microcytic, classify it as anemia, iron deficiency or thalassemia. So during the first trimester, always preferably if it is severe, go with the blood transfusion. Mild and moderate means, again, if the patient is having vomiting, you go with the blood transfusion itself. That is, parenteral iron cannot be given in the first trimester. In the second trimester, if it is less than 7, go with the transfusion. If it is 7 to 10, again, moderate, severe. As all of you told, we can go with the parenteral. Third trimester, if it is less than 36 weeks, whatever we have talked, we can discuss. If it is more than 36 weeks, if it is severe or moderate, better to go with the blood transfusion. So if the patient, anemia patient comes for in a labor, so what are all the precautions you will take? Dr. Jayalakshmi, you are there, no? Dr. Sadhana is there, I think. Dr. Sadhana?
Yes, madam. So during labor, usually we make the mother to lie in a prone position, upright position, or a prone, or in a 15, or in a, upright position, madam. Usually cut short the second stage of labor using, if the labor is prolonged, we cut short the second stage of labor, and active management of third stage, we usually resort to it. If there is, we don't manually remove the placenta, we wait for the separation of the placenta, and the PPH measurements should be followed strictly.
Sadhana, are you aware of this E motive? What is that E motive bundle? It's for PPH. Now the WHO and the FIGO, all of them talk about this E motive bundle that is in the PPH cases. Nothing, it is only the early detection, massage of the uterus, as you told the third trimester, oxytocin drug. Now we go with the tranexamic acid. Start with the IV fluids and examinations. So this is the E motive bundle now, which is mentioned by the FIGO and Japaigo. All of them talk about this E motive. This is mainly for the PPH, what we are doing. So if this is the important for PGs and all, now the E motive is the routine question in the recent advance. So for completion, I mentioned this E motive. So as you told, the second stage has to be cut short. Mainly the blood products has to be kept ready if the patient is 9 grams or 10 grams, because after the delivery, minimum of 2 grams will be lost. Always keep ready, and better to deliver in a institute where all facilities are available, and PPH drugs should be kept ready. Do you go with methogen nowadays?
We don't resort to methogen nowadays, madam. We use only oxytocin in the form of IM or intravenous drip. We don't resort to methogen or carbetocin.
80s and all, methogen was the drug. It should be given before the delivery of the shoulder, and it will reduce the complication. But now the methogen itself is not available. Still in Mudaliar, it is mentioned. So this is the labor management. How the iron, do you counsel anything when the iron tablet is given, telenacea, in the OP patients?
Yes, ma'am. Iron tablet should take the empty stomach early morning, and mostly in the first, they will not tolerate. So better to avoid with tea, coffee, with thyroxine tablet. At least 2 hours before anything, have to take iron tablet. And better to have with the orange juice, lemon juice.
That is vitamin C. So the main thing is you should counsel the patient not to take the iron and the calcium together. We forgot, Dr. Aditya, in the labor management, do you have anything to tell about that labor management? Anything iron corrected patient coming for in labor? Do you want anything to be added? We discussed, I forgot to ask you.
No, ma'am. Basically, it is basically not to offer them a physiological second stage. You offer them active second stage of labor, and then you deal with any complications that happen, ma'am. And obviously, you keep blood products ready in case of known anemic patient going in labor.
So always it is safer. The anemia patients only, the MMR, the 50% is mainly with the anemia. So always keep all products ready and PPH drugs ready. So I think the transfusion already we have discussed severe anemia in all trimester, and for PPH, blood transfusion is the treatment. And first trimester, any mild moderate, we have to go with the transfusion. So this differentiation microcytic already everyone has told. So if the patient is not going to respond to oral iron, we think it as the, as Aditya was telling, with the electrophoresis HbMN, whether it is the thalassemia, major or minor. Almost I always used to tell it is better to screen the thalassemia before conception. So if it is not available in the government hospital, in the private, we can do it. Because if the patient comes with thalassemia triad means, we can counsel we can see for her husband and see whether it is triad minor or major, like that. So the Mensur index already Dr. Jayalakshmi has explained this for practical purpose. Since the electrophoresis is not available, we teach our students and the junior assistants to go with this Mensur index if electrophoresis is not available. So now we will come to this case. This primary 34 years with a thalassemia triad. Husband is a normal. How will you proceed with this case? Oh, we can go with Dr. Alagasakti. This patient is coming to your center, Mambalam, Primary Health Center.
She is thalassemia triad, ma'am.
Yes.
So
minor.
So if she is going to be minor only, then if she will be having anemia or something, we have to correct her blood transfusion. So since she's triad, there won't be mostly problem. We have to screen for a husband. The husband is also negative, then we can consider as a normal pregnancy only. But we should follow up her closely. In any anemia, we should correct her at any trimester.
So the screening has to be done, and you cannot continue with the oral and the parenteral iron. Dr. Aditya, do you want to tell anything?
No, ma'am, they actually tolerate oral iron very well, so it usually isn't a problem.
Minor.
Most patients with the thalassemia traits, they tolerate oral iron reasonably well.
So you don't go with the blood transfusion unless if it is not severe hemoglobin.
Exactly, ma'am. It depends on her HB. But
yes,
most of them can maintain a HB of more than 9 to 10 if given iron treatment.
So that's the reason I brought this. That thalassemia minor only, husband is normal means you can continue as per recent the oral iron also. If it is severe only, we need to give the blood transfusions. Otherwise, iron itself is helpful. So that's the reason I mentioned this cases. And other than this, these are all inheritance. Both parents have thalassemia. What will be the carrier test? If it is a husband is positive, a triad, and both the triad means baby will be having. So this is the person. So according to this, minor or major, we have to treat. Minor cases is like a normal anemia only. Major only, we should be very, very careful. So how are you going to deliver this patient alone? This triad, as you told, it may not be difficult. Suppose if it is some complication, yes, Aditya, how are you going to deliver this type of patients? Vaginal or cesarean? Are you going to use intravenous chelations or third stage management?
Ma'am, basically, I would keep blood products. I would have a much lower threshold of transfusing her. But other than that, cesareans can be reserved for routine obstetric indications. We don't necessarily need to have do a cesarean. They can have a trial of normal delivery. And any patient who is anemic will obviously, you'll recommend active management of third stage of labor.
These chelations, do you give for this intravenous
deferoxamine? No. I've never used the IV chelation for a thalassemia minor patient, ma'am.
For major?
A trait patient. Yes, sickle cell positive patients and thalassemia majors, yes, you need to use chelation in those cases.
So the take-home message is, if it is a minor means nothing to worry, it can be conducted, but you should be very careful. And if it is a major only, whatever we are dealing with, the chelations and the transfusion, and cesarean is indication only for the obstetric indications. Because for this triad, cesarean is not needed. So for completion, we can go with the macrocytic anemia. Dr. Sadhana, can you tell about the macrocytic anemia?
Macrocytic anemias, like when the volume MCV is more than 100 FL and the hemoglobin is low, we label them as macrocytic anemia. Most common would be B12 and folic acid deficiencies.
So that
we also
yes.
So serum folate levels and B12 levels are to be measured, and if they are low, we can get them corrected.
Do you go with the serum B12 and serum folic acid for iron deficiency anemia itself? In the government hospitals itself, we give the folic acid, and B12 injections also we give monthly once like that. Do you measure serum B12 and serum folic acid for all patients?
No. We don't measure folic acid and B12 levels. Just the MCV levels alone. MCV is more than 100. We label them as macrocytic. And usually we rarely see such kind of patients because folic acid is usually supplemented conceptually and throughout pregnancy.
Nowadays, B12 is also advisable to give. Dr. Aditya, what is your opinion about serum folic acid and serum B12?
Ma'am, red cell folate levels are more sensitive compared to serum folic acid levels to diagnose anemia. But again, in India, we give folic acid to every patient. That is a standard recommendation. So it is very, very unlikely that we'll come across a patient who's deficient in folic acid. With B12, yes, in case of a true vegan who doesn't take any animal proteins, they are likely to have a deficiency of vitamin B12. But the advantage of vitamin B12 is that if you have a normal vitamin B12 level, or even if you have a suppressed B12 level, your body stores enough B12 for at least 1 year. So the actual clinical deficiency would show up only in cases of extreme malnutrition clinically.
Yes. So the serum level for folic acid and B12 is not needed as all iron contains the folic acid. And B12, as he is telling, we can the store will be there. But sometimes in our places, in our hospital, we routinely give the B12 also for safe side.
Okay.
There is no side effect for this. So the management, as already told, dietary changes, food and folate and B12, and otherwise the prenatal, the complications are same. So for the conclusion, in the MMR, the major 50 to 55% is due to anemia. That is the hemorrhage. So always you should correct the anemia. And our take-home message will be the anemia should be treated before pregnancy. When a girl is 12 years, her hemoglobin should be 12 grams. If you don't correct it, it will be continuing. So this is the best way. Pre-conception and all, we can correct this during adolescent. And iron-rich diet is always advised. Cause of anemia. If you are not able to do the electrophoresis and all, cause has to be identified, and proper management, when to give oral, when to give parenteral and transfusion in severe cases. And if the patient comes at 4th month, and if she is not coming for follow-up, in Tamil Nadu, we have the phone number and ID card. That is the Pick Me number. So you call the patient and follow up the patient. Because when she comes in the labor with 4 grams, we will be held up. That MMR, she may not be understanding. So always follow up the patient with the paramedical workers. And if you don't have any facility, kindly refer at the earliest stage with the hospital where the facilities are there. So in this way, we can reduce the MMR. That is the reason I took this anemia as the talk for this Pinnacle. So I thank Dr. Aditya for his wonderful input, and Dr. Kirana Selvi, Dr. Jayalakshmi, Dr. Alagusakti, and Tillai, and Dr. Sadhana Devi for the wonderful interactions for this panel. Thank you.
Thank you.
Thanks a lot, ma'am. Thank you.
Thank you. So that is only the practical case, anemia. What we are, everyone will be seeing this cases continuously. Yes, Dr. Madhumita, for the completion of our vote of thanks. So Dr. Madhumita is not there. I think I myself, she would have gone for some emergency. I thank all the societies, that is Raftulj and Ampala and Dibrugarh and the Salem Society President and Secretary, for because this is the post-Deepavali. In spite of that, we had a good registration and wonderful discussion. And I thank all the panelists, Dr. Kirana Selvi, Jayalakshmi, Alagusakti, Tillai and Sadhana Devi, and the Pranay sir for being the chief guest and guest of honor, Dr. Vidya Prabhakar, Dr. Saravana Kumar for the wonderful talk, and Dr. Aditya for his wonderful input. Thank you, Aditya. You are coming in this Pinnacle for the second time. Thank you. And we will call
Thanks a
you
lot, ma'am.
next.
Thank you.
Thank you,
Thank you,
Dr.
ma'am. Thank
Madhumita,
you
for
for
the
inviting
wonderful
me.
coordination and all the delegates and the faculty. Thank you. Thank you.